There we go. Okay, welcome everybody. This is, we're actually dialing in from the T.E.A.L Ovarian Cancer Community Center in Brooklyn. We're located right by Prospect Park, and we offer a lot of programs for ovarian cancer patients, families. We have 3 parts to our mission. We promote awareness and education of the signs and symptoms. We provide support to survivors and their families, and we fund medical research. We do a lot and have a small staff and a beautiful community center in Brooklyn. So if anybody's ever able to visit us, we welcome you. And we have a lot of in-person workshops like this evening's event. So thank you for joining us, and we hope that you enjoy. I'm going to just tell you a little bit more about T.E.A.L before I turn it over to our special guest tonight. We spend a lot of time getting out in the community. As some of you may know, ovarian cancer doesn't have a screening test, but it has signs and symptoms, and we try to educate the public as much as we can about it. So you may find us at a health fair, at a hospital, or a school nearby at any time during the day throughout the city. We also have some wonderful programs for survivors. We find that it's so important to part of the healing process for other survivors to connect with each other. So if anybody's listening and wants to meet other survivors or find a way of connecting in any way for themselves or their family, please reach out to us, as we have a lot of support groups and art therapy classes and a lot of activities that people can do even if they don't live in Brooklyn or can't commute to us. You can also dial in and call in at times. We also fund medical research at some of the country's best institutions and hospitals around the country, and we have a wonderful scientific advisory board, which Dr. Chi is a part of, and it's such an important part of the process. As you guys know, we need to provide more funding for research that's so critical to this disease. And of course, we can't go without doing a little bit of education about this disease for anybody on here that isn't familiar. There's no accurate screening test for ovarian cancer, and it's so important to know the symptoms and risk factors. It's usually diagnosed at a late stage, and we do a lot of education about those risk factors and genetic testing and genetic counseling. So if anybody is looking for resources in any of those departments, please let us know. We'd love to help. And of course, we advocate to listen to your body, know the symptoms, and keep doctor appointments. Don't miss those annual screenings. It's so important, not only for gynecological screenings, but those basic annual primary care doctor appointments. It's just so important to keep up with your health and listen to your body for what it's telling you. And then I'm going to give you guys a little bit of a heads up where we have so many activities coming up, and some of you may have heard of Giving Tuesday. We're having a really fun open holiday party here at our location in Brooklyn. Everybody's invited. And also we have some support groups coming up. One of our last ones for the year is December 11th. It's a Monday night. We've been partnering with SHARE, some of you may have heard of, and that's been an ongoing support group for survivors. We also have been around for 10 years now. We've hit our decade mark, and we've got a beautiful gala coming up in April of 2018. If you're interested, save the date, and more information will be coming soon. So if there's anything that you're ever looking for resource-wise, and we might be able to help, even if you don't see it on our website, please reach out to us, and we'd love to help in some way. And lastly, I think it's time that we turn this over to Dr. Chi. Just give us a moment as we try to switch gears. And we're going to introduce, we really thank Dr. Chi for making some time for us tonight. So our moderator is Dr. Dennis Chi. He's an attending surgeon at Memorial Sloan-Kettering. He's the Deputy Chief of Gynecology Surgery Services and is head of the Ovarian Cancer Surgery Section. We really thank Dr. Chi for making time for this tonight, and we're just going to take a moment to share his screen, which I think has just popped up. Dr. Chi, can you hear us?
Yes, I can.
Great. I'm going to pass it over to you. So welcome, Dr. Chi, and thank you.
Well, Thank you all for whoever's on this webinar for taking the time out of your busy days or day to listen to what I have to say and to participate in this webinar. I also want to thank Pamela, Sabina, and Melissa for their patience in guiding me through how to get these slides up and to you all. If there's any communication or technical difficulty, please stop me. I'm just sitting in my office going through these slides, and so if you have to interrupt me, if you can't hear me or if the slides aren't going through, please go ahead and do that. It's really not a big deal. So thus far, can everybody hear me? And should I proceed with the slides? Are we good?
Yes, everything's going great, and we can see your screen. So go ahead.
Okay. All right. So let's see. So 2 disclosures. I am on the medical advisory board for 2 surgical companies. Haven't really done much with them, but they just asked me for my advice regarding surgical products. So the reason why I wanted to speak about surgery for recurrent ovarian cancer is because the people who are presumably listening to this webinar, you are the knowledgeable ones. You are the ones who can pass the word and understand the nuances of ovarian cancer, things such as the first surgery is one of the most important factors, and where you have your surgery is important, but some of the other nuances that you may or may not know about because perhaps you had one treatment and you're in a remission, or you had a second or third line treatment and everything is going fine, is the fact that it's not just about the drug therapy that is leading to improved outcomes in our institution and others. It's this whole idea that there are many, many places that they just have a one-track method as to how to treat their patients. And I think we'd all agree, if it's you or me or my relative, I want to make sure all options are thought about and considered when my loved one or my friend develops recurrent ovarian cancer. So obviously this is a case study that I'm going to present to you, and I'll give you the conclusion at the end. Obviously, I'm picking something that supports my hypothesis or what I'm trying to say. But nevertheless, this is something that not all institutions would agree with what we did. So, a 64-year-old with a history of stage 3C high-grade serous ovarian cancer, and I know that you all know that we think that high-grade serous ovarian cancer really starts in the fallopian tubes, but that's a topic for another discussion another day. I did primary cytoreductive surgery on her many, many years ago, included a hysterectomy, BSO, the standard fare, and then 2 years after completing her primary chemotherapy, she developed recurrent disease on a follow-up CT scan. So what should we do? Should we give surgery? Should we restart her chemotherapy? Should we do a clinical trial? Should we just monitor her until she develops symptoms and then start one of the other treatments above, some other management schema? Well, here's some commonly held thoughts about recurrent ovarian cancer. Now, do you see on your screen, do you see the red things, or do you not see them, the red, like, X's, circles?
We can see them just fine.
Yeah, they're not supposed to be there.
Oh.
It's supposed to be one of those slideshows where, yeah, so I guess in this slideshow it doesn't work. So anyway, what it's supposed to be is supposed to be the 2 top lines that are commonly held thoughts that all patients with recurrent ovarian cancer are incurable, so surgical debulking is useless and should never be offered. I don't believe that, and we don't believe that here. That's why there's that red mark there. It's supposed to kind of fly in later, but I guess the slides aren't doing what I want them to do. Another thought is that all patients with recurrent ovarian cancer should be offered surgical debulking since it's of uniform benefit. And I get a lot of that. I get a lot of people who are not good candidates for a second surgical debulking procedure, and they feel like, well, why can't you just get the cancer out? And there are situations where we should do another debulking operation, and there are certain situations where we shouldn't. So secondary cytoreductive surgery is a beneficial option for selected patients whose disease is thought to be platinum sensitive, whose recurrent disease is thought to be platinum sensitive. And that's pretty much if the cancer comes back 6 months or greater after you complete your initial therapy. So in our example, it was 24 months later. So just to get some definitions down, I'm sure this is a very educated group of women, but sometimes people have a confusion regarding a second look surgery and a secondary cytoreduction, and they think secondary cytoreduction is after they started, maybe they had a laparoscopy, then got chemo, and then had a second surgery. So what I just said about a laparoscopy and then chemo and then a second surgery, that's what's called interval cytoreduction. That's being used a lot in Europe, Asia, and it's becoming more popular in America, although I'm not wholeheartedly for that. I think it has a role in certain situations. Again, something that we can talk about at a later date. But generally the way the timeline goes is that, at least in our institution and many others throughout the United States, you have a primary debulking surgery. You don't have another surgery. You get your primary chemotherapy, and then you go into your first remission. And if that remission lasts 6 months or greater, and then the cancer comes back, that's a first recurrence. That's thought to be a platinum-sensitive recurrence. If the cancer comes back in less than 6 months after finishing your chemotherapy, then the patient is thought to have a platinum-resistant recurrence, and another surgery wouldn't be considered, and retreating with platinum-based chemotherapy wouldn't be considered also. But that's not what I'm talking about now. I'm talking about the subset of patients who have perhaps, maybe they didn't get treated with initial surgery. Maybe they had what's called the neoadjuvant chemotherapy approach, where the disease was thought to be unable to be debulked, so they started with chemotherapy for 3 cycles, did interval surgery, 3 more cycles, and then went into a clinical remission that lasted 6 months or greater. The whole notion of a second look surgery, we don't do that a lot anymore. It used to be done here and in other places when we would treat with 6 cycles of IV chemotherapy, then do a second look surgery to see if there was persistent disease, and if there was a small volume amount of disease found at second look surgery or no disease found at second look surgery, we would put in an IP port and give intraperitoneal chemotherapy. That we don't do it much anymore here, and I don't think any place does. So the whole notion of second look surgery is really just kind of as a lesson of the history of the evolution of how we're treating ovarian cancer. So the topic of today's talk is those patients who've had their initial chemotherapy, whether it was neoadjuvant or after primary debulking, they went into a remission that lasted at least 6 months, and they developed their first recurrence. Another talk is a second, third recurrence. Do you do a tertiary or quaternary debulking operation? When do you do palliative surgery for bowel obstruction? All great topics, but not for today. So the whole notion of secondary cytoreductive surgery, let me just take a step back and say it's in the 1970s that the whole notion of primary debulking surgery was made famous by Tom Griffiths. But so it's pretty well accepted that if you can surgically remove all the tumor at initial diagnosis, that is the best way to go. But then the question then becomes, well, if the cancer comes back, well, how about another surgery? And if it comes back again, how about a third surgery, et cetera, et cetera. So this has been debated amongst experts in our literature for decades now, with the first publication by Jonathan Berwick in 1983. He's out in California, and you can see it was far from a robust study. There was only about 30 patients or so in the study, and some of them had bowel obstructions. So that's not really who we would consider. Remember, if you looked on that timeline, that's kind of like at the end of the timeline, not near the middle or the beginning. There were only truly 9 patients who had what we would consider today a secondary cytoreductive surgery for platinum-sensitive recurrent ovarian cancer. So it's been controversial for decades. When should a patient have another surgery for her recurrent ovarian cancer? Rob Bristow, a good friend from California, and I did a meta-analysis published in 2009 where we looked at the literature, and there were over 40 studies in the literature containing over 2,000 patients during the time period from Berwick's study to 2007. and we basically wanted to see what were some of the benefits and outcomes of doing a second surgical procedure. And so, first off, again, in those 40 studies of 2,000 patients, the estimated blood loss was really not that bad. Some of those patients could have a second surgical debulking and not even need a blood transfusion. They can be long. They can last anywhere from 2 hours to 10 hours. And 1 out of 5 patients will have some sort of morbidity, some sort of complication, but the mortality within 30 days is less than 2%, which is about what it is when you do the debulking surgery in the initial primary setting. But the crucial thing that came out of that meta-analysis was that if you have a center where it's not going to surgery, and I don't jokingly, I kind of mockingly say this, it's not doing the surgery, it's doing the correct, appropriate surgery. Exposing somebody's abdomen to air doesn't make the cancer go away. You have to have the surgical commitment and philosophy that you're going to remove all evidence of cancer, no matter how big or how small, whether it's 10 centimeters or 10 millimeters. The goal of the operation is to remove all visible evidence of cancer. So in those 40 studies, and when you compared study versus study, in the studies where complete removal of all the tumor was attained, for every 10% improvement in, let's say, study A versus study B, those patients had a prolonged survival of 3 months, just based on every 10%. So in other words, if the complete cytoreduction rate was 50% in one study, and the complete cytoreduction rate was 30% in another study, on average, the patients in the first study with a 50% complete gross resection rate, on average those patients lived 6 months longer. Now these are just numbers, but the reality is, and you may say that, 3 months, 6 months, that's not a lot, but we're talking not overall, we're talking for every 10% increment. The other thing that we found was that the year of publication, the later the publication, the more impact comprehensive surgery had on patient outcomes. And as time has gone on, our surgeries have gotten better, both in our institution, myself, I'm better now than I was 10 years ago, and throughout the United States with better training, and throughout Europe even with better training, surgical outcomes are better with every passing year. So this is just graphically explaining to you how, depending on the study, if somebody had got all the cancer out in 50% of their patients, they may have a median survival of 30 months, but if it was only 20% of patients who had a complete gross resection, then the survival was as much as 9 months less. And so when I give my lectures, I liken this to, you can take your muffler's broken. You can take it to a place. They can pretend they fix it, but if they don't fix it, they're not doing anything. You may have to pay them, but they didn't fix your muffler. Same thing. The goal of the operation is not just to make an incision on the belly, whether it be open or laparoscopy, and expose it to air or carbon dioxide. The goal is to spend 3, 4, 5, 8 hours and surgically remove all the visible cancer. This can sometimes be difficult when you're dealing with hundreds, if not 1,000 or so tumor nodules. So trying to look at this prospectively, I have to admit the Germans are ahead of us. The AGO is the German equivalent of the United States Gynecologic Oncology Group. It's a cooperative gynecologic oncology study group with multiple centers throughout Germany and sometimes throughout Europe, cooperating together to enroll patients to have big prospective randomized and other types of studies. So in 2006, Philip Harder published this paper with the notion that they were eventually going to do what they recently just showed that they could do, and that is to see, is it possible that doing a second surgery can be proven to be associated with a survival benefit in patients with recurrent ovarian cancer. So they studied 260 patients from 25 centers, and they basically requested that 25 centers throughout Germany send their results of patients who had a second surgery for recurrent ovarian cancer. That CGR, you're going to see that over and over again, complete gross resection. It's not easy. I invite any of you to come to my operating room when somebody has 1,000 tumor nodules from the diaphragm to the pelvis, including the small and large bowel. It's not easy to get it all out. But nevertheless, in this study, about 50% of patients had all the cancer removed, and if the patients had all three of the following, the AGO score was quote-unquote positive. If, as we talked about, the disease-free interval was greater than 6 months, but they also had a good performance status, very, very healthy. After their initial surgery, they had a CGR. They had no residual disease. After their initial surgery, which is not always the case, but this is what they found. And then they didn't have a lot of fluid, cancerous fluid in their belly called ascites. If the patients had all three of those, 2 out of 3 wasn't good enough, but all three, good performance status, no residual disease, no or small volume ascites, then doing a secondary cytoreduction was thought to be a benefit. And so they used that patient population, a very strict, restricted patient population, to go to the next couple steps. So that led to Desktop 3. Desktop 2 was another retrospective study, but Desktop 3 was a prospective randomized trial of patients who had platinum-sensitive recurrent ovarian cancer, and the patients were randomized to surgery and chemo versus chemo alone. There was central randomization at the AGO office. There was central data management, on-site monitoring of key data, a very, very well-done study. The primary endpoint is what we all want to know. Does a second surgery lead to improved overall survival? Do patients live longer if they have a second surgical procedure? They plan to do an interim analysis after 122 overall survival events, and there's some statistical mumbo-jumbo there, but the bottom line is in the secondary endpoints were, okay, you did the surgery or you gave the chemotherapy, how long was it till the patients developed their second recurrence? So this is the randomization scheme. The patients this is their very first relapse, not their second or third or fourth. They had to be sensitive to chemotherapy. They had to have those 3 criteria of complete cytoreduction at their first surgery, good performance status, not a lot of ascites, and they got randomized. 400 patients or so got randomized to a secondary debulking and then platinum chemotherapy versus going straight to chemotherapy. And this is some of the data that you can see basically like you would want in any randomized trial. Since it was randomized, basically the demographics and tumor characteristics and what the patients got as far as chemotherapy afterwards should all be pretty much balanced. And so when the p-value on the right-hand side is less than 0.05, you know that it was a well-balanced study. It wasn't like only the good prognosis patients got surgery or only the good prognosis patients got randomized straight to to chemotherapy, salvage chemotherapy. It was very, very balanced. More demonstration of how well balanced the study was. About 90% of patients in each group got platinum-based chemotherapy because they were platinum sensitive. About 20% of patients in each group got Avastin. And at the time of the study, PARP inhibitors weren't then what they are now, so very few patients got PARP inhibitors, at least after initial surgery or initial salvage chemotherapy. Obviously, the patients who were randomized to chemotherapy first didn't have surgery, so there wasn't any data on that. But in those patients who had surgery, the average time was about 4 hours or so, 3.5 to 4 hours. A third required a bowel resection. Not too many, less than 5% had a stoma. The blood loss was very, very good, with a median of only 250 cc's. That's really quite excellent. But 1 out of 5 got a blood transfusion. The bottom line is that this data, these complications, at least in my mind, are very acceptable. And in 72.5% who underwent surgery, they got a complete gross resection. So the 2-year survival rate was 80%, and it was much better than they thought when they first started. And then so this is just a lot of statistical analysis that tries to kind of explain where we are now. And the bottom line is that we don't have the overall survival analysis for the groups just yet because they're doing so well. Both groups are doing so well. But what we do have, and what was presented at the ASCO meeting in May, is the progression-free survival, and that's what I want to share with you now. So, in my mind, and I know people may say, this is Dennis G just simplifying things. In my review of the literature, when I read the literature, the PFS benefit is usually, not always, but usually if there's an improvement in progression-free survival of 3 months, then you can kind of think that the overall survival may be 9 months. It's usually a factor of at least 2 or 3. And sometimes not. Sometimes the progression-free survival is improved and the overall survival is the same. Sometimes it's a little bit better, the overall survival. But nevertheless, I think this is tremendously encouraging. So in those patients who had surgery, including those who couldn't get all the cancer out, just those who were randomized to surgery, there was almost a 6-month improvement in progression-free survival by doing the surgery. So, and then you say, okay, so just by exposing the patient's bellies to air, Dr. Chi, you said exposing the abdomen to air didn't help. So the patients who you exposed them to air, their survival improved by 5.6 months. No, these are statistics. So those patients, when you look at the subset analysis, those 25% or so where the cancer didn't all get removed, there wasn't any difference in progression-free survival. But the reason why the overall progression-free survival, the reason why the progression-free survival in those who had surgery was 5.6 months is because 72% had a complete gross resection, and their improvement was 7.2 months, even greater than 5.6. So basically, the 5.6 is an average, a weighted average, of the 72% that were here and the 25% or so that were here. So overall, the approach, the intention to treat is better if you were to do surgery, and it's associated with a 6 to 7 month improvement in progression-free survival, which, as I just said, may translate into a 15 to 21 month improvement in overall survival if, my hypothesis about a third pans out. And this just shows how long it took for them to, how much longer it was that people were off chemotherapy, and then the time that they had to go to third-line chemotherapy, 7 months on average. This includes everybody, those people who didn't get all the cancer out. So about a 7-month improvement that in time that you're off chemotherapy before the cancer comes back. I'm sure those people who've been on chemotherapy, a 7-month time off, that's really quite good. So this just talks about some of the morbidity and complications. Not really anything too significant, but the patients who didn't have surgery, they actually had more leukopenia and neutropenia, but that's not really a big point of this study. And just to put things into perspective, I would like to say also that these are the slides that are courtesy of Andreas Dubois. He's the chairman of the AGO, and he kindly provided these slides for me. So if you look at some of the big trials, chemotherapy trials, I know that those of you who've had recurrent disease or know people who've had recurrent disease, and a lot of centers is recur, chemo, chemo. And then after you get some chemo, how about some more chemo? Where surgery's not even considered. But if you look at these trials, if you look at the progression-free survival improvement, the best one is the Oceans trial of gemcitabine, carboplatin, and Avastin that led to Avastin being approved by the FDA in the second-line recurrent ovarian cancer setting. And the improvement was 4 months. And you're getting 16 months of Avastin. Now, I'm not against Avastin, but I'm against those people who completely think that surgery is something that we should not even consider. When not 16 months of surgery, maybe 16 hours, but one surgical procedure led to an overall improvement in 5.6 months in progression-free survival. That's as good, I don't want to overstate it, but as good as any other of these big studies in the literature that have looked at various kinds of chemotherapy and targeted agents. So the conclusion of Dr. Dubois' AGO study is that this approach of surgery led to a meaningful improvement in progression-free and time to the next chemotherapy of 5.6 to 7.1 months, at least comparable to a lot of the other phase 3 trials in the second-line setting. And there really wasn't much morbidity and mortality. So therefore, they feel, and I'm sure this is going to be the standard in Germany, secondary surgery should be considered in patients who have those 3 criteria, the AGO-positive patients. But the benefit of surgery was exclusively seen when the surgery is done to the point where you got all the visible tumor nodules out. That indicates that you both need to have the right center, the right hospital, the right institution, the right surgeon, and in their minds, the right patients. You have to select the patients well. Just another note, and there are many people on this webinar who may feel the same, differently, but this is a very old study that I quote all the time because I don't know if you all can hear this in my voice, but this is my passion. This is what I've been doing for 20 years, what I will operate on for 8, 10 hours to help my patients get better, and I do think that they appreciate it. This was a study done by Donovan in 2002 where they asked 81 ovarian cancer patients and 75 patients who didn't have cancer, would you desire aggressive therapy for your recurrence? Cancer patients said yes, 86%. Controls said only 57% would want aggressive salvage or secondary treatment. What would be the median survival of therapy that would want you to switch from just palliative care to aggressive care? And the cancer patient said, just buy me 5 months. That's all I want. The control said 8 months. We bought you 6 months of progression-free survival in that AGO study. So the conclusion of this trial, or this study, was that the majority of women desire continued aggressive treatment, even if the outcome is going to be poor. So in the green here is where the AGO study was done, mostly in Europe and in Asia. But in the red is where the American GOG trial is being done on the same topic, mostly in America and Canada. So this is the GOG, the same trial that the AGO is doing. And right now I don't have any good surgical data to report to you other than the fact that accrual is pretty much there, but we're waiting for the follow-up events to occur. But in the meantime, those patients who qualified because they're AGO positive is very, very few. In our experience, it's maybe a quarter of patients with recurrence would qualify for the secondary cytoreduction based on that AGO study. So I repeat, these are the patients who would be offered secondary cytoreduction based on the AGO studies. But who really are the ones who would benefit? Is it those patients who have a long platinum-free interval or a 6-month platinum-free interval? What if the surgery initially was done at a local hospital and there wasn't a complete gross resection? That patient wouldn't qualify for a secondary cytoreduction. Maybe they came to a very, very big cancer center. Maybe should you punish that patient or not allow them to have a secondary cytoreduction because the first surgery wasn't done as comprehensively as it could have been done at a cancer center? And in those studies by Harder, in that original study, 50% of patients had a CGR. Can we make that higher? So in other words, can we offer secondary cytoreduction to more patients so that more patients can benefit from these excellent results? So we published way back in 2006, way before that AGO study was being done, way back in this study that dated back to 1987. We published that patients who had a secondary debulking for recurrent ovarian cancer had a 56-month median overall survival. Pretty good after recurrence if we could get virtually all the cancer out. So if we could get all the cancer out, the median survival was 56 months. But other things that came into play on whether or not we would the patients did as well as 56 months or not was, well, how long was it before the cancer came back? If your cancer comes back in 30 months, you're going to do better than if your cancer comes back in 12 months. And how many sites of disease? If it comes back in multiple places, it's not as good as if it comes back in one place. And if it comes back diffusely, what's called carcinomatosis, those patients don't tend to not do as well. So this is what we've offered our patients since this paper in 2006. If their cancer comes back and they're platinum sensitive and it's only in one place, we will operate on them uniformly. If it's in multiple sites, but they've only been off chemotherapy for 6 to 12 months, maybe yes, maybe not. It depends on how they're doing, where the sites are, how healthy they are, like in the AGO study. If it's 6 to 12 months since they've been off chemotherapy, but it's diffuse disease, we're not so sure that that's a patient that we want to operate on. So this is the only group, those who have diffuse disease and have a very, very short, what's called disease-free interval, that we wouldn't consider or offer another surgery to. A Chinese group in Fudan, T.E.A.L, then took some of our data. So I'm involved in this paper, and from multiple other centers, Germany, California, Europe, and they came up with what's called a T.E.A.L score. And this is a model for who you should operate on for recurrent ovarian cancer. And the bottom line is, it's so complicated. I'm the second author on this paper. I don't even understand this model, and I don't even use it because it's too complicated. And I'll show you that it's really, I question whether it's of benefit. It is a little more accurate, and it is a little bit more reliable than what I just showed you, but it's so complicated I'm not exactly sure it's something that I'd want to use in everyday practice. So Renee Cowan is a fellow, our ovarian cancer research fellow, who looked at our secondary debulking cases from 2001 to 2014. And as I said before, patients who had their first recurrence, and we wanted to see, well, how well were we doing with that smiley face criteria that we were using. We wanted to identify those who underwent the secondary surgery, how their survival outcomes were, and prepare it and compare it to that German model, the AGO score, positive and negative, and the T.E.A.L model, which are those that are most cited in the literature as being the ones used to determine who should have a secondary cytoreduction. The compliance was quite good. Well, we made the model here, so 98% of eligible patients did undergo secondary cytoreduction. A few just patients wanted to undergo secondary cytoreduction, so they kind of pushed for it, even though they wouldn't have necessarily met the criteria. So there was high compliance, and it was very easy to use. And these are some of the things that were reported in those 200 patients that we operate on for recurrent disease. They're usually advanced stage, had papillary serous, high-grade cancers. But after their first surgery, circled here, about half of patients still had residual gross disease after their first cytoreduction, their primary. So based on the AGO criteria, these patients here would not have even been offered secondary cytoreduction based on the AGO studies. Another 15% wouldn't have been because their performance status wasn't that great, wasn't perfect. But in our study, even though we enlarged the number of the patients who we would offer secondary cytoreduction to, we got all the visible cancer out 87% of the time with a very acceptable complication rate. So in looking at our 200 patients, the 200 patients that we operated on, only based on the AGO criteria, only 49% of those would have been operated on. So 51% of the patients that we operated on would not have qualified for another surgical cytoreduction, and in my mind, the benefit of a secondary debulking. The MSKCC versus that T.E.A.L criteria, not much different in terms of who we'd operate on versus who we wouldn't. But here's the impressive thing. Of that 200 patients, the average time to recurrence after we did that secondary cytoreduction was 21 months, which is comparable to what you see in primary treatment settings, whether it be primary chemo or primary surgery. And even more importantly, the overall survival, look at that overall survival, and those of you who know, look at any studies. that look at overall survival. The overall survival in those patients who were, yes, this is a selected group of patients, who were selected to undergo a secondary cytoreduction, their overall survival was 82 months. That's 7 years after their surgery, not for initial primary debulking, for secondary cytoreduction. And this is obviously the same thing. Those patients who got a complete gross resection, they lived amazingly 95.6 months versus 57.5 for those patients who we weren't able to get all the cancer out. And yes, just as I said before, those who recurred quicker tended to do not as well as those who recurred later on down the line. So remember my case study of my patient who was 64 years old, developed recurrence 24 months later? This illustrates something that we found in 25% of our patients who we did a secondary debulking. When you hear a lot of doctors talk, they'll say, well, every remission gets shorter. You have a 24-month remission, then we treat you. Then you have a 12-month remission, then we treat you. Then you have a 6-month remission, we treat you. And it gets slower and it gets less and less and less. 25% of patients of our 200 patients had a longer second remission than first remission. So for my patient, her initial surgery was 1997. She completed chemotherapy in 1998. She had a second cytoreductive surgery by us in 2000. Then she had chemotherapy that was completed in 2001. I see her now. I don't need to see her that much because she's been out without evidence of recurrent disease for 16 years. So in conclusion, we now have level 1, the best level evidence that secondary cytoreductive surgery for platinum-sensitive recurrent ovarian cancer is associated with a survival benefit, albeit in select patients. It's my feeling that the AGO selection criteria used in that wonderful trial, though, is a little bit restricted. And it's our feeling here that our selection criteria can allow a higher percentage of patients with platinum-sensitive recurrent ovarian cancer to derive the maximum benefits of secondary cytoreduction. In expert centers, this can lead to very high rates of complete cytoreduction, complete tumor removal, and improvements in survival, and we feel it should be routinely considered in this patient population. I'd like to thank all my colleagues here at Memorial, and we are one of the first institutions in the country to have a team of ovarian cancer specialists dedicated solely to the surgical and medical treatment of patients with ovarian cancer, and that we call ourselves Team Ovary. Again, thanks to Pamela, Sabina, and Melissa for allowing me to share my thoughts with you. I'm happy to take any questions.
Thank you so much, Dr. Chi, for a very informative webinar. We'd like to now open up to some questions. I'll remind everybody how to do that. There's a little chat icon that you can click on and type in some questions, and we've been receiving some all along, so I will start with them, and we'll answer as many as we can for the next 10 minutes or so we have left. So, Dr. Chi, what advice do you have for someone with stage 2C who's platinum resistant?
It depends when they're platinum resistant. If they're 2C and they're platinum resistant initially, I would say, there's all different kinds of platinum resistant. There's platinum resistant where they may have had suboptimal surgery and they got chemotherapy, and then the cancer was in remission for a while, then came back in 6 months, so they're technically platinum resistant, versus somebody who had complete cytoreductive surgery, got chemotherapy, and then during the chemotherapy, the cancer progressed. Some people would call that platinum refractory. So it really depends, and there's others who you may have had a first surgery in chemotherapy, a second surgery in chemotherapy, recurred again, and the second or third recurrence was within 6 months of the completion of the platinum-based chemotherapy, so it really depends. My thinking is that to always consider surgery first, and if there is a possibility that surgery can be performed safely and effectively, consider that. If not, then basically the general mantra to those patients, if surgery is not an option, those patients who develop platinum-resistant recurrence, you obviously need to be treated with another salvage regimen, whether it be Doxil, gemcitabine, topotecan, Avastin, possibly PARP inhibitors, depending on the situation, the BRCA status. So there's a lot of different options.
Okay, thank you. I think you answered a couple of questions there. Do you recommend cytoreductive surgery after first reoccurrence when chemo has already been started for a platinum-sensitive patient?
Really, really good question. Generally not, because once you've already started your chemotherapy, you kind of want to give it time to have it take effect. But what I sometimes do is I see patients who develop recurrence and they've started their chemotherapy, and I would say, let's say you were planning to get 6. If they really wanted to consider surgery, maybe like with interval debulking at primary treatment, I would see them halfway through, and if it looks like things were going well but not great, then maybe do a second cytoreduction then, and then finish off cycles 4 through 6 after that. If, on the other hand, they've started their chemotherapy and after 2 or 3 treatments everything's melted away, then there's no reason that if it's not broken, don't fix it. Then I would say just keep on going with the chemotherapy and see what happens. If, on the other hand, they're progressing through chemotherapy on their salvage chemotherapy, then again I would say, well, let's see what we can do and see if we can restart the clock and maybe do a debulking and then change chemo. Okay,
thank you. In your opinion, how effective is the CA-125 test in helping to monitor reoccurrence?
In our experience, we never published this paper, and patients ask me sometimes. I order and we all do, so I shouldn't just say me, but we order the CA-125 and the CT scan, but we've never published this paper. But if you look at patients who develop recurrent disease, 15% of patients will have a normal CA-125, but will find the disease on a CAT scan. So while the CA-125 is great, and oftentimes the CA-125 can become abnormal 6 to 9 months before you can see it on a CAT scan, everybody's a little bit different. Some people develop a CA-125 normal CAT scan recurrence. Some people both become abnormal, but others you have to watch out, because while the CA-125 is very, very nice, 15% of the time it could be normal and the cancer could be back.
Okay. How would you determine who's eligible for HIPEC, the HIPEC?
Yeah. Sure. That's a very, very well-educated audience. In our institution, we're doing HIPEC for patients who develop their first platinum-sensitive recurrence. Pretty much that table that I showed you, those patients who we would offer secondary cytoreduction, we offer secondary cytoreduction and HIPEC. In my understanding of the literature, it's difficult to distinguish whether HIPEC really works or the patients who get HIPEC had really, really good surgeons and surgery. Generally speaking, you only give HIPEC when the surgical debulking has gotten the disease down to minimal or complete gross resection. So those patients may do very well. So really the only way you can distinguish whether it's the good surgery or the look at what happened in the AGO trial. The good surgery alone improved progression-free survival by 5 to 7 months. So surgery alone, regardless of whether you get HIPEC or not, can improve progression-free and hopefully overall survival. So the best way to prove that is I think with one of the studies that we're doing and others are doing. Everybody who gets recurrent ovarian cancer and qualifies based on our criteria go to surgery, and then in the operating room they get randomized to HIPEC chemotherapy followed by 5 cycles of salvage chemo versus forget the HIPEC and go straight to 6 cycles of chemo. And preliminarily, we don't have any results other than to say that the HIPEC wasn't at all as toxic as we thought when we started the trial. I don't know if the overall progression-free survival will be improved. I do know that there were 2 HIPEC presentations at ASCO this year, and one showed, and it's going to be published this year, and I think the New England Journal of Medicine, one showed HIPEC at interval debulking was associated with a survival advantage. It's from the Netherlands, but from South Korea, the same schema, the same design, showed there was no difference. So it's really, really hard to figure out whether HIPEC really works, or it's the surgery that works, or possibly HIPEC would work in certain patient populations and not others.
Okay. I think we have time for maybe one more. So anybody else who wants to get a question in, I'll leave it open another moment. But one of the last questions we have is, how can someone determine if they're platinum sensitive? Like, what makes you guys determine that?
So everybody gets one surgery and generally about 18 weeks of chemotherapy. And let's say you finish your chemotherapy on January 1. So if the blood tests and the CAT scans show that there's no disease recurrence and everything is normal, you're in quote-unquote a remission for 6 months. So that would be, I guess it's July 1. If there's no evidence of cancer recurrence from January 1 to July 1, you're quote-unquote platinum sensitive. If, on the other hand, the CA-125 goes up, or physical exam reveals a mass, or the CAT scan shows something before July 1, then we consider those patients platinum resistant.
Okay. Well, I think that's all our questions tonight. That concludes tonight's webinar with Dr. Chi, titled Surgery for Recurrent Ovarian Cancer. We ask that you guys all take a moment and fill out a survey that we're actually just emailing to everybody tonight. You're going to get an email as soon as this is over, and that really helps us just make all of our webinars better and better. We also just want to remind you that there's a lot of events coming up. I know everyone's busy for the holidays. For us, there's quite a few events coming up, and we do appreciate you taking your time out of your busy evening tonight to just spend a moment and listen to the wonderful information that Dr. Chi just shared with us. So thank you, everybody, for attending, and we hope everyone enjoys the rest of their night. So thank you again, Dr. Chi.
Thank you all.
Okay, have a good night, everybody.
Happy Thanksgiving.
You too.